Welcome back to The Explainer. We're jumping right into a really complex, fascinating, and honestly pretty challenging autoimmune disease today, systemic sclerosis, or SSC. We're going to take a comprehensive, outside-in tour of exactly how this condition presents clinically. So we'll be tracing its path from the visible surface of the skin all the way deep down into the vital organs.
Now, think about this for a second. What happens when the very mechanism designed to repair a simple cut just malfunctions? Like, what if it runs completely out of control, replacing your healthy, flexible tissues with rigid, unyielding scar tissue? Well, okay, let's dive into this. That runaway healing process is literally the fundamental engine driving systemic sclerosis.
Here's our anatomical roadmap for today. We'll start with the hallmarks of SSC, then move to skin and vascular symptoms. After that, lungs, heart, and breathing, followed by the kidneys and GI tract. Then we'll hit muscles, joints, and antibodies before wrapping up with the very real dangers of untreated SSC. All right, Section 1, the hallmarks of systemic sclerosis, and specifically the core triad.
So the term scleroderma literally translates to hard skin. But the disease actually goes way deeper than the surface. It's driven by this fundamental triad. First, small vessel vasculopathy, which basically means the blood vessels are damaged. Second, autoantibody production, where the immune system is actively attacking the body. And third, fibroblast dysfunction. That's what deposits excess collagen and leads to fibrosis or severe scarring. Together, this triad works to completely dismantle normal tissue function.
Clinically speaking, patients generally fall into two main buckets based on their skin involvement. You've got limited cutaneous systemic sclerosis, which primarily affects the skin below the elbows and knees, and it tends to have some really prominent vascular features. Then, on the flip side, you have diffuse cutaneous systemic sclerosis. This involves rapid, extensive skin thickening that can actually cover the limbs and the trunk. Now, while both are incredibly serious, the diffuse subset carries a much faster, more aggressive trajectory for internal organ fibrosis. Moving on to Section 2, let's look at the skin and vascular presentations, essentially the outer layer.
For the vast majority of patients, the absolute first warning sign is Raynaud's phenomenon. If you haven't seen it, it's a really dramatic, exaggerated vascular response to cold or stress. There's this classic three-phase color change in the digits. First, ischemia causes the fingers to turn stark white as blood flow just drops. Then, hypoxia turns them a bluish-purple color. And finally, as the blood rushes back in during reperfusion, they turn bright red. It's an incredibly common early marker of the disease's underlying vasculopathy.
But here's the thing, Raynaud's isn't just some annoying nuisance. It's a severe lack of blood flow. And if left untreated, this ischemic cascade has some pretty horrific consequences. That persistent lack of oxygen literally leads to the breakdown of skin, forming these exquisitely painful digital ulcers. Eventually, if ignored, this can progress to tissue necrosis and even gangrene, which can tragically result in autoamputation or the surgical loss of the fingertips.
Now, what's really interesting is how the clinical criteria formally define these other visible markers. Under the established definitions, we look for things like puffy fingers, which is this diffuse swelling that basically obliterates the normal contours of the digits. We also see telangiectasia. Those are the visible, dilated, superficial blood vessels you might spot on the hands or the face. And crucially, if we look under a microscope, we find abnormal nail fold capillaries. We're talking about enlarged or even missing microvessels right there at the cuticle. These are the undeniable visual fingerprints of systemic sclerosis.
All right, Section 3, lungs, heart, and breathing. We're moving into the vital organs now. Take a look at the actual scoring system rheumatologists use to classify this condition. Notice how heavily two specific internal manifestations are weighted here: interstitial lung disease, or ILD, and pulmonary arterial hypertension, or PAH. The fact that they carry so much weight really highlights an important point. While this disease might be recognized by what's happening on the skin, it is absolutely defined by its systemic internal reach. And there's a very good reason those conditions are so heavily weighted. If left untreated, the fibrosis of interstitial lung disease relentlessly scars the delicate air sacs of the lungs. It progressively suffocates the patient from the inside. Meanwhile, pulmonary arterial hypertension drastically increases the pressure in the blood vessels of the lungs. This forces the right side of the heart to pump against immense resistance, which inevitably leads to severe right-sided heart failure. Make no mistake, without targeted therapies, these cardiopulmonary complications are the leading drivers of mortality in SSC. Section 4, kidneys and the gastrointestinal tract. This is where we uncover the hidden damage. Now, this statistic is just staggering. Roughly 9 out of 10 patients will experience GI involvement. 9 out of 10! What happens is the fibrotic process thickens the walls of the esophagus and the intestines, basically destroying the normal muscular contractions. And this untreated dysmotility, it leads to severe acid reflux, difficulty swallowing, malnutrition. It causes a drastic collapse in daily quality of life. And then we have the kidneys. Scleroderma renal crisis, or SRC, is arguably the most feared acute complication of this entire disease. It primarily strikes patients who have the diffuse, rapidly progressing form of SSC, and it is a true life-or-death medical emergency. It's characterized by a sudden, terrifying spike in blood pressure paired with rapid, acute kidney injury. Just to be absolutely clear about the stakes here, if a scleroderma renal crisis goes untreated or unrecognized, that accelerated hypertension is going to rapidly destroy the kidneys. It leads directly to permanent kidney failure, requiring lifelong dialysis. In fact, historically, before modern interventions, it was almost universally fatal. That sheer urgency is brilliantly illustrated in the emergency management workflows for SRC. Notice the immediate, aggressive use of AC inhibitors, drugs like ramipril or captopril, as the absolute first-line defense. You can see the pathways for high-dependency unit monitoring and the stark warnings for things like seizures or pulmonary edema. It is literally a race against the clock to lower that blood pressure and save renal function. Section 5. Muscles, joints, and autoantibodies. Let's talk about the systemic glue holding this clinical picture together. The autoantibodies produced in this disease aren't just random markers. They actually act like a crystal ball for clinicians. For example, if a patient has anti-centromere antibodies, we know they're at high risk for the limited cutaneous form and pulmonary hypertension. Anti-topoisomerase 1, that flags a diffuse form and a really high risk of lung scarring. And anti-RNA polymerase 3 is the major red flag for rapid skin thickening and that terrifying scleroderma renal crisis we just talked about. Testing for these specific antibodies allows doctors to anticipate and screen for the absolute worst complications long before they strike. Beyond the internal organs, the fibrosis also viciously attacks the musculoskeletal system. The skin tightening can literally lock the joints in place, creating these severe contractures. Patients can develop tendon friction rubs, which is exactly what it sounds like, inflamed tendons scraping against each other, and muscle weakness, or myopathy. If left untreated, this total loss of joint mobility effectively traps the patient within their own hardening body. And that brings us to Section 6, the overarching danger of untreated SSC. So the absolutely crucial takeaway here is this. Systemic sclerosis is not just a skin disease. If that underlying triad of vasculopathy, autoimmunity, and fibrosis is left unchecked, the resulting cascade dismantles the body system by system. Think about what we've covered, from gangrenous fingertips to suffocated lungs, a failing heart, destroyed kidneys, a paralyzed GI tract, and locked joints. It is a relentless, total systemic takeover. But as our understanding of these pathways grows, so do our medical interventions. We're finally moving from just managing symptoms to actually modifying the disease process itself. So, with such a complex systemic takeover, what does the future hold for targeted therapies, like biologics and antifibrotics, to finally halt this relentless disease once and for all? Well, that is the fascinating frontier of modern rheumatology. Thanks for joining me on this explainer today. Keep learning, stay curious, and I'll see you next time.